Bismillahirrahmanirrahim. Honorable chairpersons, respected panelists and learned audience, Assalamu alaikum and good afternoon to all. I am Dr. Sonya Begum Rodela, affiliated in Clinical Oncology Department, Delta Hospital Limited as Junior Consultant. Welcome you all to my presentation. I am very much delighted to be a part of the 19th SARC Federation of Oncologists and Bangladesh International Cancer Congress 2024. Thanks to organizing committee for giving me the floor. This study entitled as Exploring Clinical Utility of Adjuvant Chemotherapy versus Adjuvant Chemotherapy followed by concurrent chemoradiation for resected periampullary carcinoma. Periampullary carcinoma is a malignant tumor originating from the area within 2 cm of the ampulla of Vater. It comprises pancreatic head malignancies, ampullary cancer, duodenal papillary cancer, and distal common bile duct malignancies. According to Globocan 2022, it is 12th most common malignancy and 6th leading cause of cancer mortality. As per Hospital Cancer Registry Report, Delta Hospital Limited from 2019 to 2023, total number of new cases diagnosed as periampullary carcinoma about 770, that was 11.9% in total cancer patients over the given period. Periampullary carcinoma is a formidable destiny in the field of oncology, characterized by its aggressive nature, late-stage diagnosis, and dismal prognosis. Treatment typically involves surgical resection followed by adjuvant treatment with chemotherapy and radiotherapy. Recent advancement of surgical techniques have reduced perioperative morbidity significantly, but long-term survival cure rates remain low. Even after radical surgery, 70% patients develop distant metastasis, 30 to 50% patients experience recurrences following surgery, and prognosis remains poor. Different modalities of adjuvant therapies aim to improve survival, but results are inconsistent. Patients with high risk of recurrence post-operative concurrent chemoradiation is a particularly effective approach. In National Cancer Database studies from 2004 to 2015 have shown overall survival benefit with combined chemo followed by chemoradiation that was 19.5 to 25.2 months. In our context, different adjuvant comparative study between different modalities of adjuvant treatment is still limited, so this study aimed to evaluate the outcomes of adjuvant chemotherapy followed by concurrent chemoradiation compared to postoperative chemotherapy alone. This study also focused to identify the high-risk patients who benefit most from adjuvant treatment. Objectives were, the general objective was to evaluate the outcome of adjuvant chemotherapy versus chemotherapy followed by concurrent chemoradiation for resected periampullary carcinoma, and specific objectives were to assess the efficacy and to compare the toxicities between two treatment arms, to determine the overall survival and progression-free survival between two arms, and to identify the prognostic factor and socio-demographic characteristics of the responders. It was a retrospective analysis conducted in the Clinical Oncology Department, Delta Hospital Limited, and patients were recruited from January 2019 to January 2024, and purposive sampling technique was used based on the inclusion and exclusion criteria. 70 patients were analyzed, 35 patients were allocated in each arm. Arm A received adjuvant chemotherapy alone with gemcitabine and or capecitabine or platinum-based drugs, and Arm B received adjuvant chemotherapy followed by concurrent chemoradiation. Radiation dose was 45 gray with 5 to 9 gray boost over 28 to 30 fraction using 3-dimensional conformal radiation therapy with concurrent capecitabine. And target area was post-operative tumor bed with adequate nodal coverage with respect to organ at risks. Inclusion criteria was histopathologically proven periampullary carcinoma with ECOG performance status 0 to 2. Criteria for adjuvant chemotherapy, that was Arm A, T1 to T3 lesion and N0 to N1 nodal status, lymphovascular space invasion, perineural invasion, and criteria for adjuvant chemotherapy followed by concurrent chemoradiation, T1 to T4, N0 to 2 nodal status, pathologically positive margin, that was R1 resection only, pathologically positive regional nodes, raised tumor marker after chemotherapy, pain and obstructive symptoms after chemotherapy. Exclusion criteria were metastatic or unresectable disease at surgery, indolent tumors, patient treated with palliative intent treatment with neoadjuvant chemotherapy or radiotherapy, poor performance status, or life-threatening comorbidities. Study endpoints were primary endpoint was overall survival and secondary endpoint was progression-free survival and toxicity analysis. Results and discussion. Regarding patient characteristics, the mean age of the patients of both arms approximately around 50 years of age. Male predominance were slightly observed in arm B group, 37.1% patient in arm A and 42.9% patient in arm B had history of smoking. Chronic pancreatitis were observed in 14.3% patient in arm A and 20% patient in arm B, whereas diabetes mellitus were 45.7% patient in arm B and arm A and 40% patient in arm B. Chronic pancreatitis and diabetes mellitus distributions did not differ significantly between two arms. Regarding patient characteristics, grade 2 tumors were more prevalent in arm B group and there was higher proportion of the positive nodal status and margin status were observed in the arm B group. And slightly more common perinodal space invasion and lymphovascular invasion were in arm B group compared to arm A group. Majority of the patients in both arms were in stage 2. Distribution of the patients according to the occurrence of the obstructive jaundice. Before treatment, the frequency of the occurrence of obstructive jaundice in arm A was 14.2% and after treatment it reduced to 5.7%, and in arm B it was 42.8% and after treatment it reduced to 17.1%. Distribution of the patients according to positive abdominal lymphadenopathy in post-operative setting. Pre-treatment frequency were in arm A were 22.8% and after treatment it reduced to 8.5%, and in arm B it was 54.2% and after treatment it reduced to 14.2%. Distribution of the patients according to race CA19 marker and compared between two arms. Pre-treatment in arm A it was 48.5% and after treatment it reduced to 25.7%. And in arm B, it was 68.6% and after treatment it reduced to 37.1%. Distribution of the patients according to the toxicities between two arms, and it was done by common terminology criteria for adverse event version 5. Majority of the patient in arm A and B had grade 1 to toxicities of nausea, vomiting, loss of appetite and myelosuppression, but they were in the manageable limits. On the contrary, few number of the patient developed abdominal pain, diarrhea, dyspepsia, abnormal liver function, that was grade 1 and also in the manageable limit, but there is no statistically significant difference between the two arms. Time to event data, including overall survival and progression-free survival, were analyzed by the Kaplan-Meier curve and compared between two groups using log rank test. In arm A, median overall survival was 23 months and in arm B that was 27 months. The hazard ratio was 0.626 and p-value was not significant. Regarding the progression-free survival in arm A, it was 15.3% and whereas in arm B, it was 21%. The hazard ratio was 0.45 and the p-value was significant. Cox regression model was used to identify the influencing factors influencing the overall survival and progression-free survival. Influence of the abdominal lymphadenopathy. Lymphadenopathy did not have a significant impact on overall survival and progression-free survival compared between two arms. Influence of obstructive jaundice. The presence of the obstructive jaundice did not show significantly impact on OS and PFS between two arms. An effect of race CA99 on overall survival and progression-free survival. There is no statistically significant difference in overall survival between two treatment arms for patients with race CA99 levels. But the hazard ratio for arm B compared to arm A was 0.45 and the p-value was significant. Patient and interpretation was the patient treated in arm B have a statistically significant lower risk of disease progression or death compared to arm A for race CA99 cases. So we can summarize the key findings of our studies. Progression-free survival, there was significant improvement of progression-free survival in the chemo followed by chemoradiation group, but there is no statistically significant improvement of overall survival. It was just marginal trend, probably due to smaller sample size. and nodal positivity was slightly higher in the arm B group, but the improves over outcome for high-risk patient, although it was statistically not significant. The findings of our study align with the Mayo Clinic and NCDB studies in respect to chemoradiation efficacy and raised CA19 level, manageable grade 1 toxicity, grade 1 to toxicities in both arms similar to the findings of some studies. This study concluded that adjuvant chemotherapy followed by concurrent chemoradiation shows a significant benefit in progression-free survival and has similar toxicity profile compared to adjuvant chemotherapy alone. Raised tumor marker CA19 and patients benefit more from chemotherapy plus chemoradiation, supporting its use in high-risk patients. Limitations were smaller sample size, larger multicenter study needed, heterogeneity in the disease presentation, long-term follow-up needed for better understanding of recurrence pattern, quality of life, and full impact of adjuvant therapies. And future outlook is larger cohort study to further validate long-term survival outcomes and effectiveness in diverse population, investigate biomarkers like CA19 to better tailor treatment, explore personalized treatment strategies integrating genetic profiling to optimize patients' outcome. These are the references. I am very much thankful to my mentors and Clinical Oncology Department and Institutional Ethical Review Board, Delta Hospital Limited, and my heartfelt gratitude to Assistant Professor Dr. Kamrujjaman Rumman sir for taking this challenge as Principal Investigator and Professor Dr. Kazi Monjur Kadir sir for overall supervision. Thank you so much. Still there is a hope. Thank you so much for patience hearing.